Welcome to the webinar, Community Management of Heart Failure, Optimizing Self-Care. And thank you to the Community Health Nurses Initiative Group for being interested in this topic. And my name is Karen Harkness, and I'm glad to bring you this webinar on behalf of the team at the Cardiac Care Network of Ontario. What I'd like to do in this webinar is to talk a little bit about education and strategies to support self-care in people with heart failure. And there's three parts of self-care that I want to talk about. There's self-care maintenance, there's symptom monitoring, and then there's helping patients with the management of changes in their signs or symptoms of heart failure. Just to recap, heart failure is a condition where the heart is unable to pump enough blood to meet the metabolic demands of the body. Sometimes this can happen because the heart is too weak. Sometimes it can also happen because the heart is too stiff. Regardless, the ideas of self-care are applicable regardless. Just to keep in mind that self-care is difficult for patients with heart failure, and often we notice that they seem to be getting older and more complex, and in fact that is the case. As you will see, compared to 1997 to 2007, and here we are another 10 years later. But as you will see, heart failure is common in both men and women, but you'll see that the age is getting a little bit older. Some people have ischemic heart disease or underlying coronary artery disease, but many don't. Hypertension is common, so is diabetes, COPD, atrial fibrillation. And this last one is a score on how many comorbidities you have, and the higher the score, the more complex. And so there are more people with complex comorbidities. So in fairness, self-care is difficult for patients with heart failure, and hopefully with the coaching we can help them figure out what's important to help feel well and stay active and have a good quality of life. The other thing that is difficult with heart failure is that it is characterized by, on this graph, where at the top where you feel well and have high functioning, and then you get these periods where you feel unwell and your symptoms are worse and you end up going back to hospital. And unfortunately, this trajectory can be quite unpredictable. But what we do know is there are times with heart failure where you can feel quite well and quite stable, and then things start to deteriorate. Often the symptoms start to get worse, and it takes on average a person 5 to 7 days before they seek hospital care, and that's where the symptoms have got to the point where they're extremely noticeable. What we'd like to do is try and encourage patients to seek care or have a plan on what to do when symptoms start to occur, so that way they can catch them early and avoid acute care utilization. The management of heart failure is rather complex, and there are many things that are needed in order to help the people feel better. See what is the trigger, what is causing the heart failure in the first place, and is there anything that's reversible with that. But we also want to help them avoid ongoing hospitalization, help them feel better and improve their quality of life, and if it's in their goals of care, we certainly want to help them decrease mortality. To do this, you need multiple care providers. You need medications. They need some education about self-care. There needs to be discussions about goals of care. There certainly are disease management programs which take a team approach using specialists, and there is a number of device therapies, which is an implantable cardiac defibrillator or cardiac resynchronization therapy. However, for the presentation today, we're going to talk a little bit about self-care. In heart failure, self-care is often defined as a naturalistic decision-making process, and it really looks at trying to maintain stability, looking at your symptoms, and then being able to do something about those symptoms if they change. So using a picture, there's three different components of self-care. There is maintenance, which is treatment adherent, which is taking the medications as prescribed, trying to stay as active as possible and engaging in regular exercise, and doing things to lower your risk factors, such as controlling hypertension or sugars if you're diabetic. Then there's the part about symptom perception, where patients do have symptoms of heart failure that may improve or may get worse, and it's trying to monitor those symptoms so they know what to pick up, and it's really a surveillance system and recognizing what to do if things change. So when they do pick up a change, the next step is what should we do, and have a plan or an action plan, as they often describe, on when and how and where they need to seek some help. From a patient's perspective, it really is the maintenance is what do I need to do to help feel well and prevent the heart failure from getting worse? What are my symptoms of heart failure and how are they different from the usual pattern? And often people's symptoms of heart failure will follow a similar pattern with them. They may experience shortness of breath, others may experience swelling, others may experience a cough. The bottom line is people often have the same grouping of symptoms that they need to watch for. And then if they do notice a change, what do they need to do about it in something that is a meaningful way to help prevent it from getting worse? Some of the self-maintenance activities which we help patients with is trying to come up with a system to remember how to take all those medications. And the average patient with heart failure often takes 9 different medications a day. That's a lot of pills. And so hopefully there's a system that helps them remember it doesn't matter what system as long as it works well for them. Obviously, quitting smoking is important. Some people have a weak heart from alcohol, so if that's the case, we want them to refrain from alcohol completely. Some people may have a little bit of alcohol, it just counts as a fluid. The big salt debate, obviously if they have high blood pressure, they need to lower their sodium intake for the blood pressure guidelines, and we really ask people to get rid of that salt shaker and avoid that sodium bolus. We want them to stay active, and even if it's just general walking, a little bit, a couple of times a day is certainly meaningful. The idea is to keep active in whatever way is possible. And then a system for monitoring their symptoms. Daily weight is very common. Some people aren't able to see the scale or get an accurate weight, so we have to come up with other ways to try and help them monitor their symptoms. Symptom management is a little bit harder, and we try and teach patients to think of being a detective. And so how are they feeling today, and is there a change? And if there is a change, why is there a change? Is it important to change? Gee, I'm up 2 pounds. Oh yeah, I can be up 2 pounds, and that's usual for me. What do I need to do? I don't need anything to do right now, but I'm going to monitor it for another day and then see what's going on. And the next day, do I feel okay? Yep, my weight's down, all is good. However, no, my weight's up. What do I need to do? Now I need to start worrying about my action plan and what goes on. So this kind of problem-solving approach is really important to catch those symptoms early and have an action plan. And often patients really need help with personalizing this process. It's interesting that when we talk about as healthcare professionals, there are these guidelines that tell us how to manage heart failure, and yet often we'll hear the healthcare professionals say, but how do I apply it to our patients? Can you give me some samples or examples? Can you give me some case studies? How do we do this? The same holds true for patients and caregivers. They who have heart failure, we give them a lot of education materials. However, what they really want to is, how do I apply this to my life? How do I know how it fits with my daily routines? And can we go through some examples? Can we plan ahead so we know what to do when those situations arise? Sometimes there is such a disconnect and a lot of uncertainty between information we provide for people and then how to execute. And as you can see here, the information on here, it says dial 999 for these people. However, when you try and execute, I can't find any 999 on this telephone. And so often what people are reading and what people have to do to execute, there is a disconnect, and it does seem quite confusing. So how do we help them? Here's some examples, some cases, and I want to introduce you to Mrs. Tetley. She was recently admitted with pneumonia and some heart failure, and so she was discharged from hospital, and you see her 4 days later. She's actually doing quite well. No changes in her weights, her symptoms are stable, and things are going as planned. 2 weeks later, however, she comes in and you see her as an appointment, and you can see that she's got her weight log and she wrote down the weight, and you can see there's been a 10-pound increase over the last 2 weeks. She's also noticed that her abdomen is distended. She's got some peripheral edema. She's having trouble sleeping at night, and now she uses 3 pillows to prop herself up to sleep. If she uses less than 3 pillows, she feels she's very uncomfortable with her breathing, and that's called orthopnea. So when she elevates the head of her bed, things settle down. She's also quite tired and has a poor appetite, and she's just finding it interesting that here she is gaining all this weight, but she's not eating much. On exam, her blood pressure is reasonable, 146/68. Her pulse is 75 and regular. Her lungs are clear. There's no fluid that you can hear of. Her jugular venous pressure is elevated, and her abdomen is distended, and she has pitting edema to her knees. So what's going on with Mrs. Tetley? And when you think of her symptoms, the disconnect a little bit between she's gaining weight and she says she can't understand why she's gaining weight even though she's not eating. So I think it's taking a step back and just asking her, what's going on, and what kind of symptoms did you have when you were in hospital? And even just trying to see if she can recognize her symptoms that are related to heart failure. She may be attributing to something else. And so trying to draw that connection, often they'll remember the symptoms they had in hospital. Sometimes they really can't tell you what is going on, in particular with their heart failure. Obviously, something's changed over the past 2 weeks, but people are very good at telling you a little bit about what happened. And through storytelling, you can really pick out some of those key things that are related to heart failure. So it sounds like things are going well, but now they're getting worse. Can you tell me about your routine over the past week or so? And sometimes just getting them to tell you about what they've been doing, who they've been visiting, who they've seen. You can start to pull the pieces together. I think the other thing is she actually was doing some things that are helpful with self-care, is keeping track of her weight. Unfortunately, that weight gain she didn't attribute to symptoms of heart failure. You don't want to have her feel like she's done something wrong, and the fact that she's checked her weight and you should have called me earlier, and why did you wait till there's 10 pounds, and flip it around and rather use it as a positive thing. I'm really glad you're keeping track of your weight. This is a great clue. Let's figure out a plan so we can help you before you gain 10 pounds and perhaps maybe after 3 or 4 pounds. Self-care confidence is a huge challenge, as there's so many things that they need to remember, and it can be overwhelming. And by building their confidence and building that skill set, it really helps them over time. This is not something you learn overnight. It does take practice. It's a skill. Just think of trying to learn how to play golf. You may have a bad swing in there, but you just keep trying, and over time, hopefully, it does improve. The other thing, though, that's important to help with patients is really trying to understand why symptoms did get worse. And sometimes I think our patients feel like they're coming to a confession booth because you're trying to find out what went wrong. And really what it is trying to help them identify the trigger. Whenever there is a significant change in their fluid status, there is always a trigger. And so really trying to figure out that trigger, and so patients can recognize it, but also you can make sure that whatever that trigger is, it is gone. Often I'll tell patients, often when the water builds up again, there's a trigger. Can you help me play detective and figure out what your trigger was? And so the two of you work together through problem solving. Keep in mind, though, when you are trying to look and figure out a trigger, it's not really looking for a diagnosis. That's not what we do. It's really trying to play the detective and understand what are the variables that could be playing in this situation. Sometimes they are a little bit more serious. New atrial fibrillation, you'll probably catch some of that in your travels. An irregular pulse is even one of the first clues. Maybe their heart rate is just too fast and that poor heart can't keep up. Maybe they're having some ischemia. Maybe their blood pressure is just too high and that's making the heart work hard. Or maybe they just aren't on the right pill set for their heart failure, and so it's easy for them to tip into heart failure. The other thing, though, that can be going on is what about something putting stress on the heart that isn't heart related but makes the heart work harder? For an example, they could be experiencing an infection, a urinary tract infection, a respiratory infection. Perhaps there's some problems with low hemoglobin. Many of these patients are on blood thinners, they're older, they're high risk, and they could have not a big GI bleed, but a slow and steady blood loss that's insidious but can build up over time. Perhaps it's something to do with the medications. Often they'll say, oh, my neighbor told me about this Aleve. It was great. It really helps their arthritis, so I'm trying it. The ibuprofen, the Aleve, some of those over-the-counter medications can interact with heart failure medications or put a strain on the heart. Just because they're over-the-counter doesn't mean that they're necessarily safe. The other ones are just self-care difficulties. There are some challenges with trying to keep track of medications, trying to figure out some diet situations as well. So in your mind, as you're working through some of these triggers and trying to figure out the triggers for these patients in a problem-solving approach, it's nice to have a checklist in your mind so you can go through and rule out or rule in some of the possibilities. So what happened with Mrs. Tetley? Well, we asked her what was going on, and often restaurant food is a trigger. And often I'll say, did you have an opportunity to go out for a meal? Because sometimes salt sneaks in those restaurant foods, and even though you don't add the sodium, they are high in sodium, and Chinese food is notorious. And she went on and on about, no, she hasn't been out, she's been eating at home, and it really was, well, tell me what you've been doing with your family. And it really wasn't until we found out there was a birthday party. And at the birthday party, she told me about her granddaughter's birthday and on, which was lovely, but what did you eat? And there was ham, and probably the one dose of ham really wasn't an issue, but she got the leftovers so she wouldn't have to cook. And so the family was doing a great thing at providing her with these ham leftovers. So basically she's had ham for the last couple of days. So there's a nice sodium bolus over the last 5 or 6 days, and then you start getting that fluid buildup. And often if the gut gets swollen, the tablets don't get absorbed and you end up, the Lasix isn't working at all. So do you tell her not to go to birthday parties? No, she needs to enjoy life, and those things are really important. But it's just coming up with a plan so that if there are birthday parties, how can she enjoy what's there without the sodium bolus? Here's another one about Mr. T, and these are some of the copies from his hospital records. So in May 2014, he showed up to the emergency room with worsening shortness of breath and was treated and released. July, he showed up to the emergency room for an admission of heart failure. And as you can see here in his report, they're looking for a trigger as well. Were there any changes in his medications? Is he taking his medications as prescribed? Is he following a low sodium and fluid restriction as he was instructed? Did he go somewhere and pick up a bug? Did he do anything to help? So they're definitely trying to look at triggers and for his heart failure. And so that they really couldn't find an obvious trigger, but he was admitted and discharged. But sure enough, he came back again within a couple of 2 or 3 weeks. And what they noticed is the person now is saying, hey, he's back. He's been back a couple of times now. He went home okay, He says he's taking his medications. However, now they're looking at the medications with his dosette, and what he says he's taking and what is in front with the medications and the dosette don't quite make sense. So there's starting to be a little bit of a disconnect on what he's saying he's doing and what in fact is actually going on. So he comes for a follow-up visit, and he's now about a week or so after his hospitalization, and he's already noticed that there's some more swelling. And when you talk to him, how are your weights? Oh, they're fine. Forget that. Just go, do you even own a scale? So sometimes people will say their weights are fine, but they haven't checked them, and then you find out they don't even own a scale. The other thing is are you looking for any other symptoms? He says, I'm doing well. I'm following the low sodium diet. I'm not eating out as much as I used to. I'm trying to eat at home and doing the things that he thought were really helpful for his heart failure. But what he was doing is, rather than eating out, he was getting ham and bologna and bringing it in and eating it at home. So as far as he was concerned, it wasn't takeout food. And his comment was, nobody ever told me that ham and bologna are high in sodium. So when you start hearing, nobody ever told me, you start wondering to yourself, did we actually not tell him? Or did he not hear? Or do we just need some reinforcement? Or are we just not getting the message across in a meaningful way? So how can we help? The teach back is one method of trying to identify if patients are understanding what you're telling them in the way that you've told them. So it's really about making sure they've heard the message and understand the message, and that our messaging is appropriate or helpful for them. Often I've used the excuse if I'm talking to someone, okay, your spouse or your husband or wife is going to be asking about what did we talk about today, and what are the things that you're able to share with them, or your family may be having some questions. What information are you able to share with them after our visit today? And sometimes that's just a way of asking them and getting an idea on what they really understand. Keeping in mind, we're not going to remember everything, and there is going to be a lot of opportunity that you're going to be using for reinforcement. I remember working in the clinic, and I was the only nurse, and people would be coming to the clinic for about 6 months, 9 months, and then we mentioned something about salt, and they would look at me, nobody ever told me I needed to watch my salt intake. And I'm thinking, well, I'm the only one here. Have I not been telling them, or have they not been hearing? Or maybe I just need to figure out other ways of helping them learn. And so it is understandable that people aren't going to remember, and you are going to need to reinforce and come up with creative ways to help them learn. I wanted to point out this website actually as far as ongoing learning. This is a website that was developed in Europe. It's actually a very user-friendly website, and it's just Heart Failure Matters, one large word. And as you can see on here, there are different topics that are available that they can click on. The other thing that I want to point out is this section here where it says English, and then there's a little arrow there. And if you press on that arrow, you will see that there's a number of languages that come up. And if you just click on the language that you want, it converts the whole website to that language. You can get written materials. There's also a series of very short videos. They're all less than 2 minutes. And again, it can be done provided for you in a different language if you press on that language. So a very good website, and I do find it helps not only using and teaching, but helping for reinforcement. Another case is Mrs. Gray, and sometimes we hear, nobody ever told me, but other times I hear, oh, I never realized that was part of my heart failure, or I never realized I should be paying attention to that symptom. So Mrs. Gray, she's a lovely 87-year-old lady. She lives alone. Her daughter lives nearby. She had a 3-week history of orthopnea, paroxysmal nocturnal dyspnea, which means waking up in the night gasping for air, and she has shortness of breath on exertion. She was diagnosed with heart failure. She has heart failure with a stiff heart, where it shows an ejection fraction of 62%, and she has a little bit of mitral regurgitation. She's had a history of a heart attack in the past, and she's got 2 stents. She's diabetic. She's got hypertension, hyperlipidemia. She quit smoking a long time ago. She's had a TIA for some carotid stenosis. She's got some macular degeneration and some chronic renal insufficiency.
And here we have Mrs. Gray on examination. She's a petite frame. She looks tired. She uses her cane, and she was accompanied by her daughter. As you can see, her weight is 41 kilograms, which is a loss of 2 kilograms since her hospitalization. Her blood pressure sitting is 119/40, and she does have a postural drop, as when she stands, her blood pressure is 100/40, and she is a little bit lightheaded with that. Her pulse is regular at 63. Her current medications are in a blister pack. She has both losartan and metoprolol. They may be for high blood pressure, but they're also prescribed for post-MI. She's on Agranox for stroke prevention, on a little bit of Lasix, some Norvasc for hypertension, Lipitor for her cholesterol, and she's on some diabetic medication and her Nitrodro patch. So looking at Mrs. Gray, we have 3 choices regarding her volume status. Is she fluid overloaded or wet? Is she volume depleted? Or is her volume status quite stable and she is euvolemic? So given these findings, we'll see that because of her weight loss and her postural drop, she is actually volume depleted, and so she is dry.
So the plan was, when we looked at her blister pack, she was on a wee little dose of Lasix. So we talked to her and said, why don't we take the Lasix out of the blister pack, put it in a separate bottle, and you'll take it as needed. So we said to her, watch your weight and your symptoms, and we'll see you in 2 weeks. Take the Lasix if you need it. If you're not sure, you call us. Okay. So 2 weeks later, she wanted to cancel the appointment. She's really tired. She hasn't been sleeping well in the last week. Her air conditioner is broken, and so it's hard to get a good night's sleep. And she didn't need any of those Lasix pills anyway because her ankles weren't swollen. She was telling us she checked her ankles every morning and they weren't swollen, so she didn't think she needed one of those water pills. She did check her weight as we asked, but she didn't write it down because she was worried with her macular degeneration. She really couldn't see the scale, and she didn't trust her vision. So here is a little bit of a disconnect where we've been asking her to do some things, and we're assuming that checking your weight means writing it down, calling us if there's a problem, and yet she didn't feel comfortable doing that. Her weight is now 0.3 kilograms. Her blood pressure is still a little low, 94/50. Her lungs are clear. However, her jugular venous pressure is elevated, and she has no pitting edema. So what's going on with Mrs. Gray? We have our 3 choices for her volume status. Is she wet? Is she dry? Or is she just right? And when you look at, there's been a weight gain. Even though her lungs are clear and there's no edema, her jugular venous pressure is now elevated. So I'm leaning towards the sign of wet. But the next question is, why is she wet? And if she was wet, how come she didn't think to take any of the Lasix pills? Because that was the plan. So now we need to go into that mode of problem solving and education and building capacity in a way that can help Mrs. Gray catch those symptoms. One of the ways of trying to help patients identify their symptoms of heart failure is asking them what were their symptoms when they went to hospital. And what she was telling me is they were orthopnea and PND. Did they include ankle swelling? No, they didn't. So the fact that she's checking ankle swelling is lovely because maybe her neighbor gets ankle swelling, but ankle swelling is not her clue. So you want to congratulate her on looking for something that is related to heart failure, but we need to turn it around and figure out what it's related to her symptoms of heart failure. And so we started going on about what's going on with the air conditioner. Her symptoms tend to bother her at night, and the air conditioner isn't working at night. So starting to put the pieces together, and really what happened is she was telling me that she would wake up at night feeling like she was suffocating and couldn't get air. She figured the air conditioner wasn't working properly, would get up, walk over to the window, fiddle with the air conditioner, see if that would help. But then she's wide awake, so she would end up just sleeping in the recliner for the rest of the night, and she would sleep well. So she figured it was fixing the air conditioner that was helping her sleep, when in fact it was sitting up in the chair because of the orthopnea or PND. And when we started to go through some of these symptoms, she really did have an aha moment where they looked at both her daughter and Mrs. Gray looked at each other and went, that's not the air conditioner. That actually is my heart failure. So again, you don't want to discourage her that she didn't catch it, but in fact, build that capacity. I can see why you may think the air conditioner is broken, but I'm wondering, it sounds like your problems may not be the air conditioner, but heart failure. What do you think? That could be it, and it really worked through building that confidence. So one of the things we can do as healthcare providers is really help those patients personalize their signs and symptoms. How do you know if you are starting to retain fluid? Is it your ankle edema? Is it that dry, hacky cough? Is it the needing the extra pillow? Is it the extra belt hoop that you use for the belt around your pants? What is it? You will find you will get a large variety of things that may or may not be related to heart failure, and you really have to pull out some of those key things. The other thing is really clarifying that something coughing up sputum and feeling unwell is probably not heart failure versus more shortness of breath and a weight gain. So trying to personalize those things for them. Looking at once they recognize their symptoms, then we need a plan. So for Mrs. Gray, okay, we've recognized that the PRN Lasix may be not a good thing, or maybe it is a good thing. We just need to figure out a better action plan on helping identify when she needs to take the Lasix and when she doesn't need to take the Lasix. Or maybe it's something different. It could be the action plan, could be as simple as when you need to call, when you don't need to call, when you want to call just in case, all kinds of options. Really personalize it for something that is meaningful for that patient. I put up these tests, and these are a MOCA test, which is a test for cognition, mild cognitive impairment. And we actually did these MOCA tests on people that had no documented awareness of any cognitive impairment whatsoever. And this gentleman was labeled as being non-adherent or non-compliant with his appointments. And he kept getting them mixed up, and he was getting angry. And I think what it showed is his scores actually showed on his cognitive testing that it was very poor. Here's a person that lovely, lovely man used to come with his wife to all their appointments, and she took over managing the pills, and we just figured that was what worked for them and their relationship. She ended up going back to work, so he would come in by himself, but there was still a very strong message that please call his wife. She organizes the pills. And when we did his cognitive testing, we wondered maybe she organizes the pills because he's having difficulty. It's not because that's their normal routine. It's because he couldn't manage and she has taken over that. This is a gentleman who's 78 years old. He did pretty good on his cognitive testing, but he actually is the primary caregiver for his wife. So sometimes it's not just themselves they're trying to manage, but somebody else, and that certainly complicates things. This last gentleman, we figured he was having some cognitive issues, and yet his wife was trying to cover them up by saying everything's fine, and she was managing things and really didn't even want us to talk to him because I think she was frightened we were going to find out that he was having some cognitive issues. We had already started a referral to a geriatrician. The point of this slide is these are all people that didn't have documented cognitive issues. And don't be surprised if you do need to encourage patients for learning or ongoing learning, or they have difficulty learning, especially with those detective skills. And a lot of it is just that poor brain is just not getting the whoosh, or there are some underlying cognitive challenges that do make it difficult. And caregivers sometimes get very frustrated, and yet the patient may just not have the cognitive capacity to grasp all that is needed for some of this heart failure self-care. One of the things that some of the studies have shown is that we've actually talked to patients about how they do self-care, and they actually do what we call these lay clinical trials, where they actually try things and see if it works, if it doesn't work. And some of them are actually trying to figure out a way that helps managing heart failure fit in with their life somehow. And this lady was trying to go to work, and she found that in the mornings, if she took her pills, she'd feel very lightheaded and dizzy, and then she wasn't able to drive and get to work. So this was a problem. So she stopped the medication for a couple of days, and then she started it again, but at half the dose. And then as she started to feel better, she was increasing it. But if she felt really lightheaded when she got out of bed, she would just take half a dose. So she was taking something, just in a dose that allowed her to go to work. Interesting enough, though, at the same time, she did not report this to her physician and actually lied to him about the dose she was taking because she was too embarrassed to disclose her own approach. And patients may be doing this and afraid to tell us, and it's really trying to give them permission to say some of this is difficult. Have you ever tried different ways of making it easier? And it's understandable. So giving them permission to talk about some of the things they've explored in a way and trying to make it work rather than in a punitive way. This lady, interesting enough, we saw this lady on a Friday, and she was starting to run into heart failure. And so we asked her to increase her water pills. And so on the Friday, she was taking a couple of water pills rather than a regular 2. And then on Saturday, she noticed, I'm really not peeing a whole lot with these water pills, even though there's extra. So she knew she couldn't drink water, too much water, but her neighbor said, maybe you should try iced tea, because maybe you need to flush out those water pills that you're taking and they'll work better. So drink iced tea, that'll make you pee, and the water pills will work better. So good intention. She was doing it because she thought it was a good idea. Obviously, it wasn't a good idea, but interesting enough, she gets admitted on the Monday as being non-compliant, and it's not the issue. It's the issue she was trying to do the right thing. She just was misguided. And so it's trying to figure out a way to do things in a positive way. And they're trying. There are many times when I think back to golf, I've had good intentions and the ball did not go the way I wanted, and holding the club wrong or something. The bottom line is you're trying to do the right thing. You just need some help. This gentleman, he was one of those sodium bolus guys who would come in with a couple of pounds. And through the detective work, we realized it was the Swiss Chalet, and it was that dipping sauce that really was tipping him over the edge. So he decided he wouldn't go to Swiss Chalet. He's not going to use the dipping sauce. That's not a good thing. So he went to Kentucky Fried Chicken instead, because they don't have sauce. And of course, he still ran into trouble with heart failure. And again, he's trying to do the right thing. It just didn't come out the way he had planned. So working through the idea of the Kentucky Fried Chicken, it's about the sodium and not just the sauce. And he was okay with it. It was just misunderstanding or just trying to learn. Here's an example when you're trying to work with people where they've done something and it's left a nasty footprint and they really don't want to go there again. Those darn Lasix pills. I don't take my Lasix when I'm going out somewhere. I can't always get to a bathroom quick enough. I had an accident when I was out a few months ago. I was so embarrassed I could have died. And we take for granted that finding a washroom is very easy, but could you see somebody elderly who now has to climb a flight of stairs in a hurry and they're short of breath and they have to go to the washroom because they've taken Lasix? It is very difficult. No matter how much you talk to this lady, she is not taking Lasix before she goes out. And maybe she doesn't have to. Maybe there's a way of coming up with a plan saying, okay, how do we make sure you can take that Lasix, but in a way that doesn't interfere with what you'd like to do or go out. And it's just being creative and trying to work through. Maybe they take the Lasix when they come home. Hopefully it's not too late in the day so they can still get some sleep. Maybe they're allowed to skip one day a week. Whatever it is for that patient, if you can come up with a meaningful plan, they actually will stick to it, and because it works for them. This lady, she said, my weight just kept going up. I knew if I gained weight, I would need to go back to the hospital, so I just stopped checking my weight. And so the frustration is the weight was actually a signal of trouble, and for her, trouble meant hospital, and she did not want to go to the hospital. So I think looking at what really is driving the benefit of checking weight, and there was really no benefit for checking the weight as far as she was concerned. It was a bad thing because then she knew it was time to go to the hospital and she didn't want to go. The good thing about checking weight is preventing hospitalization. So trying to spin it around so that checking the weight, let's come up with a plan so you don't need to go to the hospital. So working through some of those things. So it really is trying to understand their beliefs about heart failure. What are their expectations? And what do they really want to do in their daily life? And how can they try and encourage some of those meaningful activities and things that are important to them? Whether it's going to their bridge on Monday night, or whether it's going to their choir practice on Thursdays, or whether it's going to meet their friends at Tim Hortons, or whatever it is. What is really important to them, and how can we try and make sure that they can achieve some of those things? Really look at their home environment and trying to come up with routines. We had one lady who the idea of exercise was just daunting, and so she liked to watch TV, and we're like, okay, during the commercials, when there's a commercial, would you be willing to do 10 steps or do some arm curls or something like that? Just something that we could figure out together that she could do. The problem-solving approach for those activities that are risky, those birthday parties, those whether it's special holidays, you want people to enjoy in those in a meaningful way, but not in a way that tips them over into heart failure. And obviously the caregivers are so important, their family members or their close friends, at really trying to work together. And I think just recognizing and appreciating that it is difficult. It's not easy. It takes practice. And if you only know them for a short term, you're only going to get a small piece of the puzzle. And this is a journey of learning. And I find it does usually take a couple of months, and there is reinforcement. And sometimes they just need permission to recognize it is difficult, and you're looking for ways on trying to make it easier. So you take a lot of pills every day. It's hard to remember. Do you find it hard? Have you found anything that helps? Those water pills, oh, they're a nuisance. Some people tell me they don't take them from time to time. I'm wondering, does that ever happen with you? And I wonder if there's any good suggestions we can help. So it's just recognizing that it's not easy. And obviously the caregivers are really important, watching for that caregiver burnout, because it is difficult for them, some of those challenges, and really trying to see the patient as part of a team and involve those people, important people in their lives whenever possible. And I think in closing, people, this quote here, people don't care how much you know until they know how much you care. And obviously we need to know something about helping manage heart failure, but they really want that personal touch. They listen, they like my input. I feel so much better. They don't argue with me. They respect me as a person. They're really, really important to me and interested in me, and that relationship is key. And often you spend time just building the relationship, and then you get into some of those behavioral changes. But that relationship is absolutely important. So I want to say thank you for your time, and if you have questions along the way, you are more than welcome to email me. There's my email there. You can see the patient education website. There are some specific modules that healthcare providers can do related to heart failure, and there's a website for that one. There is no charge for those. And the other thing is there are some resources if you want to know what the heart failure guidelines are. There's a big 10-year review that is coming up and will be published in the fall of 2017, and it's a huge overview of the management of heart failure. And I say thank you very much for this opportunity.